Hello, everyone. Good morning or good afternoon. Welcome to our educational session on Plasminogen Deficiency. Before I speak any further, may I ask you to type yes in the chatting box? I just want to make sure that you can all hear me properly. Perfect, so it's coming in. So I got a few yeses, so that means everything is working well. It's great. So again, welcome and thank you for your participation. My name is Julie and I work here at Promedic under the Rare Disease Division. We are extremely excited and happy to present an overview of Plasminogen Deficiency, and we truly hope that you will expand your knowledge today. This session is going to be pretty simple. We will start with a 40-minute presentation with Dr. John Moran, our Chief Medical Officer here at Promedic. Dr. Moran is well experienced and extremely knowledgeable about Plasminogen Deficiency. And then following his presentation, we will have a Q&A session at the end where you will be able to ask a question to Dr. Moran. So without keeping you waiting any longer, I will let Dr. Moran take over with this session. And I hope you enjoyed this session. And again, thank you very much for joining us today. So Dr. Moran, I will leave it to you. Thank you.
Thank you, Julie. So let me briefly introduce myself on the second slide. You probably guessed by now that I'm Australian. I graduated from the University of Melbourne in 1969, a long time ago. So I have a lot of experience. I'm board certified both in internal medicine and nephrology. Been doing research for 3 decades or more, as the slide says. I'm the Chief Medical Officer from Promedic Life Sciences. I have an adjunct appointment at Stanford University School of Medicine since I've lived in the Palo Alto area for the last 10 years or so. So let's talk about plasminogen. It's a protein that's made by the liver and circulates normally in the blood. It activates a change. It's a substrate for an enzyme which leads to the generation of plasmin. Plasmin is a fraction of the plasminogen molecule and has many important roles in the body, but among the most important is dealing with blood clots. When your blood clots, you have a network of fibrin fibers which form the clot and stop the bleeding, whether it's a small cut or a large one. But once you've stopped the bleeding, you need to repair the wound. So normal tissue comes in and removes that fibrin that stopped the bleeding and replaces it with normal tissue or scar tissue. If you don't have plasminogen, you have difficulty removing the clot and it becomes organized and forms what are called ligneous lesions. Ligneous is from the Latin, it means woody, and typically these lesions are firm, painless, and only cause problems either if they're visual or if they interfere with organ function. So, sorry, I got a bit ahead of myself. So I'm now looking at slide 5. On the left, you see what happens in a normal situation, a person with a normal level of plasminogen in the blood. Plasminogen is converted by normal body enzymes to plasmin, and that breaks down fibrin and removes it so that the body can then repair the wound. If you lack plasminogen, as is described on the right-hand side of the slide, you are not able to generate plasmin, and you are unable to remove that fibrin clot, and it can cause either inflammation or organ damage if it's in the wrong place, if it's in an inconvenient place for the body. So I want to talk about congenital plasminogen deficiency. It's a very rare genetic disease. We'll talk about the inheritance, but it's autosomal recessive, so that means it's a very rare disease, and the symptoms and signs, the manifestations of this occur when the level is low. So here's a slide showing the inheritance. It's autosomal recessive. That means that each parent has one abnormal gene and one normal. And so the possibilities of inheritance, you would get one gene from the father, one gene from the mother. So you can see the possible combinations. If you are lucky and inherit both the normal genes from your parents, you'll be normal. You have a 1 in 2 chance of getting an abnormal gene from one parent and a normal gene from the other. So you have a 2 in 4 chance of being a carrier. If you are unlucky and inherit the defective gene from each parent, you have congenital plasminogen deficiency. So you can see how the numbers play out. If each parent has one abnormal gene and one normal gene, and if they, in theory, had 4 children, you'd have one normal child, 2 children which were carriers, but would not have any manifestations of plasminogen deficiency, and 1 in 4 of the children would have congenital plasminogen deficiency because they've been unlucky enough to inherit the defective gene carried by each parent. So we have bleeding in many places in the body, usually the skin, but other sites as well. And so the signs and symptoms of plasminogen deficiency depend on where the bleeding occurs, where the ligneous change occurs when the fibrin can't be removed, and whether it interferes with vital function of whatever organ. I'm going to go through a list of the possible manifestations. You can see that they are many, and so it's often difficult to diagnose. Doctors have 2 problems in diagnosing this. First of all, it's a rare disease, so they may not know about it, they may not think about it when they see a patient. And secondly, because it has so many different possible effects on so many possible organs, it may be seen by many different specialist doctors. So the slide shows a representation of essentially the body with the potential sites where plasminogen deficiency may lead to problems. And as you can see, there are many, and just about every organ in the body could be affected. Remember, it's a very rare disease. Even if you have the congenital plasminogen deficiency, you may have very few manifestations, very few problems. I don't want to get people alarmed thinking that all these organs could be affected. Generally, we see 1 or 2 or 3. But I'll run through the more common ones. So the eyes. so-called ligneous conjunctivitis, and there's a representation of that here, is by far the most common manifestation of this rare disease. We see it in about 80% of patients. There's probably two reasons for that. One is that obviously the lesions are very visible, as you can see in this slide. And secondly, the eye is exposed to the outside world probably more than any other organ except the skin. So minor trauma to the eye, such as getting a piece of dust in your eye, trying to remove it, may cause a little bit of bleeding. If that occurs, then you may end up with a ligneous lesion. Can't be removed without causing problems. They often recur if there's no plasminogen available. So another visible organ, of course, is the mouth, and so-called ligneous gingivitis, that is, inflammation of the gums, can occur. And that may lead to a number of problems, including tooth loss. It may lead to disfigurement in the mouth and alveolar bone loss. The bone that is supporting the teeth may erode away. Ligneous gingivitis is fairly common in patients with congenital plasminogen deficiency, so it may be diagnosed by a dentist, for instance. The skin, impaired wound healing. As I said, the process of wound healing occurs in stages. The first, the formation of the clot to stop bleeding within the wound, then removal of the fibrin clot, which stopped the bleeding, and then normal tissue repair. If you don't have plasminogen, you can't complete that wound healing. And so wounds may close, but have a lot of difficulty in healing. And remember that wounds include surgical wounds. Patients who, with congenital deficiency of plasminogen, may have difficulty getting healing of even clean surgical wounds. Respiratory tract obstruction. This is fairly uncommon, but the issue here is that you can get ligneous lesions inside the respiratory tract in the trachea or bronchi, and if they obstruct airflow, then you get lung collapse behind the obstruction. You may or may not get infection on top of it. It's, as I said, not a very common manifestation, but it can be very severe. Obviously, it depends which area of the lung and how much of the lung is damaged, but it's something that really has to be dealt with. Currently, the treatment is to excise the tissue and remove the obstruction. Congenital hydrocephalus, that's obstruction to the flow of the cerebrospinal fluid, the fluid that supports the brain and stops it bouncing around the skull. If you get hemorrhage during birth, as may occur inside the so-called ventricles where the fluid is inside the brain, then you get obstruction to the normal flow of that brain fluid and pressure building up, which can compress the brain, and it has to be treated by relieving the pressure, typically by inserting a shunt between the spinal fluid and the peritoneal cavity, so there is a artificial route to drain the fluid and relieve the pressure. That shunt is usually required for life. In the genital tract, especially female genital tract, you get such lesions in the uterus, the vagina, or the ovarian tubes, and it may be associated with infertility simply because of obstruction in the genital tract. And infertility is a relatively common manifestation in females with congenital plasminogen deficiency. Again, the management is typically surgical excision of the lesions. It's difficult to achieve success in the absence of plasminogen because, as I mentioned, a surgical wound is a wound and may have problem healing. Okay, plasminogen deficiency, diagnosis and treatment. I think it should be diagnosed at first by an alert physician recognizing the potential of plasminogen deficiency based on the problems the patient presents with. And the first thing to do is to test the level of plasminogen in the blood. If the plasminogen level is below about half normal, the subject who has the typical lesions very likely has congenital plasminogen deficiency, and genetic testing can be done to look at the plasminogen gene and find any mutations which are leading to decreased level of plasminogen. When a lesion is excised, the pathologist can do microscopic examination and has a very typical appearance, and that's another way that the lesion may be found, and in fact typically was the way the diagnosis was made before it was recognized that it was lack of plasminogen that caused the problem. So step one, laboratory testing for plasminogen activity in the blood. If the level is low, then the diagnosis should be confirmed with genetic testing. And I should also suggest that if a child presents with congenital plasminogen deficiency, then any siblings, brothers or sisters, should have their plasminogen level tested as well, because one sibling may have lesions before another, even though they both have the same congenital deficiency. So current treatment options in the management of plasminogen deficiency. It's a saying in medicine that the more treatments there are for a condition, the less likely each of them is to be successful. If there was a successful treatment, there would not be many treatments. Surgery at the moment is the primary approach. One really has to excise lesions that are dangerous to organ function or obstructing vital organs. Lignous conjunctivitis, as I mentioned, is by far the most common manifestation, and clearly those lesions need to be excised if they're likely to interfere with vision or if they're particularly distorting the eye or eyelids. Steroids, you can use either local steroids, so-called cortisone or equivalent. These reduce the level of inflammation, but will not cause total resolution of the lesion. There are topical treatments that have been used with varying degrees of success. Quite a lot of them immunosuppressive agents, such as you would give an organ transplant recipient, So significant drugs which may cause issues should not be used lightly. Fresh frozen plasma has been the standby. You take plasma from a normal person, which has a normal level of plasminogen, and infuse it into the patient. But if you do the fairly simple math, 1 liter of fresh frozen plasma infused into a patient who has a 0 plasminogen level would only raise the level by 1 in 5. You're infusing 1 liter of plasma into a circulating blood volume of 5 liters, so you could only get the level up to 1/5 of normal, or 20%. And of course, there's limitations as to how much fresh frozen plasma you can give, especially in infants or young children. There's a very limited volume you can give. Experience with fresh frozen plasma is very variable. Patients who have significant levels, even though they have the lesions, you may be able to resolve the lesion with fresh frozen plasma, either intravenously, as I mentioned, or by local eye drops. But very, very often, you simply cannot get enough plasminogen into a patient with congenital deficiency because you're infusing just plasma with a normal level, which is diluted by the patient's own plasma. Okay, plasminogen deficiency, the circle of care. I've mentioned that very many specialists may see the patient, and therefore very many specialists are involved in both the diagnosis and management. The ophthalmologist is likely to be the first person to diagnose the condition because, as I've mentioned, ligneous conjunctivitis is by far the most common manifestation. It's unfortunate that it's such a rare disease, and ophthalmologists have to think about the diagnosis, consider the diagnosis. The lesions have a very typical appearance and should be diagnosed quite easily once the doctor thinks about the condition. But as I mentioned, it's very rare, and therefore very few ophthalmologists have ever seen a case. The dentist may diagnose it if there's ligneous conjunctivitis, and again, it's less common than ligneous conjunctivitis. Very few dentists will ever see a case, but they may be the person who diagnoses it. Pediatrician manifestations may occur at birth with, for instance, congenital hydrocephalus, or ligneous conjunctivitis may occur within a few months when the baby is exposed to external environment. Neurologist, congenital hydrocephalus, if a child presents with hydrocephalus, then the neurologist has to work out why. And one of the reasons for congenital hydrocephalus that has to be ruled out is congenital plasminogen deficiency. Nephrologist, again, renal tract involvement is uncommon, but does occur and usually manifests itself as either bleeding in the urine or obstruction of the tubes passing urine to the bladder, the ureters. The lung specialist may see it, patient with obstructive lesions in the lung. Typically, that would be followed up by having a look at down into the lungs, looking at the lesions and excising the lesions if they're obstructing the free flow of air. But again, the pulmonologist has to think about the condition, this very rare condition. So in the center of the circle of care, we put the hematologist. Really, it's a disease which is related to a lack of plasminogen in the blood. It's the hematologist who will be monitoring the patient from that point of view and should be following the patient for life and referring the patient to other specialties as required to deal with lesions in specific organs, as we've listed on the outer circle. Just giving you time to read this because the slide is not advancing. Okay. For all the reasons I've just mentioned, it's important for the patient to understand their disease. I think it's a great saying in medicine that the patient should know more about their disease than the doctor, especially in a condition like this, which is so rare, has so many different possible presentations, symptoms, signs. It's very important for the patient to be educated about the condition so they can in turn make sure that the physician understands the disease. You may end up educating your doctor rather than, as is usual, the other way around. I think you need to be aware of potential issues, and if they occur, draw them to the attention of your doctor. And if you're educated, you may well be able to suggest what is required. So the PLGD community, the Plasminogen Deficiency community, patient organizations, especially with rare disease, are very, very important. There's mutual support, mutual education, and understanding of the disease, which is so important in such a rare disease. We've put the link here to a website that is one of these patient organizations, and there's a lot of information there, and I invite you to go to that site, educate yourself, and also, just as important, let other patients and their families know about this site. Sorry, do I have trouble advancing the slide? Well, I'm glad you've had time to write down that website. So, thank you. I'm going to put it back to the website, and you can make sure that you have the correct address. So, Julie, would you like to take over?
Well, thank you very much, John. That was really informative. Great presentation. I think we can't hear you properly.
And I hope I have the answer.
Yes, hopefully. Can you maybe speak a little closer to the mic? We've had some comment. We can't hear you really well. Can we do like a little bit of testing just to make sure that we hear you well? John, can you just speak a little bit? Okay. John, can you hear me? Okay, so we will start with the questions. So if you have a few questions, I will surely transfer it to Dr. Moran. So we can start with the questions now. Thank you.
So the first question is, who should I consult first if I notice any lesion? Well, my answer would be your primary care physician, and you should be referred to a hematologist for confirmation of the diagnosis if this is the first time you've had any lesions and you're not previously aware of the diagnosis. If there is a specific lesion, then clearly you need to be seen not only by the hematologist, but by specialists in the area, like an ophthalmologist for the eyes or a pulmonologist for lesions in the lung. But it should be the hematologist, I believe, who is responsible for managing your care, making sure you get the right treatments and get seen by the right specialist. So next question, should I continue with current treatment knowing that it is not resolving anything? I cannot say with certainty that it is not going to resolve anything. Fresh frozen plasma may be a treatment which could be given either into the blood or as drops in the eyes, and in any particular patient that may resolve the lesions. In many patients it won't, but I wouldn't rule out any treatment that the doctor prescribes just because it may or may not work in a particular case. I think these treatments should be looked upon not as definitive treatments, but as a trial of a treatment. So, for instance, fresh frozen plasma eye drops should be tried if there is no other treatment available, and in a particular case it may resolve the lesions or at least help to control the lesions. each patient with this disease is unique, and I would not say that any given treatment will not work in any given patient, but I would also strongly recommend that the treatments should be looked as a trial of treatment. Just like, for instance, treating a patient with high blood pressure, you try the first line agent. If it works, that's fine. If it doesn't work, you either have to increase the dose or add another agent to control the blood pressure. It's a trial of treatment for a specific patient. So next question, can I get tested even if I don't show any signs or symptoms? Well, I'd definitely say yes. If you have a sibling who's being diagnosed with congenital plasminogen deficiency, you surely should be tested, even if you have no lesions. I know of families where more than one child has been affected, yet one child may have manifestations years before the other, but the family should be tested, especially the brothers and sisters, to make sure you understand whether or not a particular sibling has the disease as well as the child that presented with the problems. Should you get tested if you don't have any signs or symptoms? I would say no, not unless there is reason to believe the disease is in the family. We have routine screening for diseases, congenital diseases like phenylketonuria, where it's a very rare disease, but unless it's recognized at birth, severe problems occur, especially mental retardation, and altering the diet can prevent that happening. So it's very important to diagnose that particular condition early, to get the treatment going early. And even though it's very rare, every child born in the United States is screened for this condition. Congenital plasminogen deficiency is again very rare. Treatment is not required unless there are lesions, so there is no screening program for looking at the plasminogen level of a newborn baby. So unless you have a sibling with a disease, I don't see any reason to get tested if you have no signs or symptoms. Okay, next question. If you have lignous conjunctivitis, what are the chances of having any other organs affected? Well, that is a difficult question to answer, but the other conditions, other organs being affected, are much less common. You may also have, say, a small lesion in the lung, which is not causing a problem because it's not obstructing the airways, and it may be there without knowing it. Having said that, involvement in the lung is much less common. I can't put numbers on it because it's such a rare disease, but lung involvement may be much less frequent, or recognized lung involvement, I should say, may be much less frequent, such as, I give you a number of 20% or less. Lignous gingivitis is probably the second most common, and I think more than 1 in 2 chance of having the gums affected. genitourinary tract, uncommon, certainly uncommon in males, more common in females, and as I said, may cause infertility. That is a relatively common manifestation in females. So just because you have lignous conjunctivitis doesn't mean you're going to suffer other problems as well, but you need to be aware of the possibilities. Last question, how can I get more info on PLGD? I put up the website, and I would put it up again if the slide would advance. I'm sorry, I can't put it up. But if you wish to know further, just email me. I'm John Moran, so my email is very simple, j.moran, M-O-R-A-N, @promedic.com, PROMETIC.com.
Well, thank you very much, Dr. Moran. That was a great presentation. Thank you to our audience. Great questions. So we thank you very much again for your participation. We hope you enjoyed this session. We will do more sessions eventually in the future, so we hope that you will participate again. So we would like to end the session today by saying a big thank you and see you next time. Thank you, everybody.